السلام عليكم. هاي المحاضرة راح نكمل ما بديناه part 1 of drugs for diabetes. راح نتكلم عن other injectable and oral antidiabetic drugs. أول جروب عندنا هو الانكريتين مايماتكس. قبل ما نحكي عن هذا الجروب خلينا نعرف شنو نقصد بالانكريتين افكت. الانكريتين افكت هو الفيزيولوجيكال ريسبونس للأورال glucose injection، وهذا ال physiological response is manifested by a higher secretion of insulin which is higher than the basal level of insulin. هذا نسميه احنا incretin effect، ونشوف انه is markedly reduced in type 2 diabetes. طبعا هذا ال incretin effect occurs because of the gut releases incretin hormones اللي هي الglucagon like peptide 1 والglucose dependent insulinotropic polypeptide as a result of ingestion of meals. من ناكل هاي الهرمونز will be released بالgut و as a result راح نشوف احنا الانكريتين effect. هذا الانكريتين effect هو مسؤول عن 60 to 70% of the postprandial insulin secretion. The main drugs that we have in this group هي Glinides والliraglutide. طبعا both of them are injectable incretin mimetics and we mainly use them for type 2 diabetes. طبعا mechanism of action مثل ما حكينا هي راح تكون through binding to the GLP-1 receptors that will trigger the activity of these receptors. As a result راح نشوف improvement in glucose dependent insulin secretion that will slow أيضا gastric emptying time, reducing the food intake by enhancing satiety و decrease the postprandial glucagon secretion. بالإضافة إلى أنه الانكريتين mimetics can promote beta cell proliferation. As a collective result of these effects راح نشوف انه ال weight gain وال postprandial hyperglycemia will be reduced, as well as نشوف انه ال HbA1c level will also decrease. Glinides والliraglutide both are or should be given subcutaneously. Liraglutide has a longer duration of action compared to Glinides because it has a long half-life. هذا ننطي اللوراglutide as once daily dose regardless of the meal، بينما الglinides ننطيه twice a day within 60 minutes prior to the morning and the evening meals. الشيء لازم نلاحظه وننتبه إليه بالglinides إنه هو will be secreted by glomerular filtration، ولهذا يكون عنده shorter half-life. فهذا لازم ننتبه عليه بالpatients اللي عندهم severe renal impairment. We should avoid الglinides. بعد ما تكلمنا عن الانكريتين mimetics هسه نجي نتكلم على oral agents to manage diabetes. طبعا هاي oral agents أو drugs اللي احنا راح نتكلم عليها هي mainly تكون type 2 diabetes that is not controlled with diet. The efficacy of these agents نشوفها the best in patients who develop diabetes after age of 40 or they have diabetes for less than 5 years. They are more likely to respond to these oral agents. في بعض الحالات نضطر انه ننطي اكثر من one oral agents لعلاج الديابيتس، وفي بعض الحالات نضطر انه نضيف ايضا انسولين بالاضافه الى الاورال antidiabetic drugs. The first group of the oral antidiabetic drugs that we have is the sulfonylurea. They are also called insulin secretagogues because they promote insulin release from the beta cells in the pancreas. And the mechanism of action of these drugs are through blocking the ATP sensitive potassium channel, resulting in depolarization and calcium influx that will lead to insulin exocytosis and the release from the pancreas. We have 3 candidates in this group. First one is the glycopyride. Second one is the glipizide, while third one هو glimepiride. Sulfonylurea may also regulate the blood glucose level through reducing the hepatic glucose production and also increase the insulin sensitivity in the peripheral, in the whole body. Their duration of action will range from 12 hours to 24 hours depending on the candidate. لهذا ممكن نعطيها مرة واحدة باليوم إلى مرتين باليوم. The second class we have is the glinides, and we have repaglinide and noteglinide in this group. They are also called insulin secretagogues because they also induce the insulin release from the beta cell in the pancreas through this similar mechanism to sulfonylurea. Having said that, they are different from sulfonylurea in terms of the onset and the duration of actions, because glinides have a rapid onset and short duration of action compared to sulfonylurea. They are important in the early phase of insulin release that occur after the meal, and they are categorized as postprandial glucose regulators. لهذا glinides shouldn't be taken in combination with the sulfonylurea because they both act through the same mechanism, and that will, giving them together, will increase the risk of hypoglycemia. Glinides should be taken prior to the meal, and they are well absorbed after oral administration, similar to sulfonylurea. الثيرد كلاس اللي عندنا من الأورال antidiabetic drugs هي البيجوينايدز، وبهاي المجموعة عندنا فقط الميتفورمين. الميتفورمين increases the glucose uptake and used by التارجت تيشو مثل ما شرحنا بالبارت 1 وأهمية الجلوكوز uptake بالregulation of blood glucose levels. لهذا الميتفورمين decreases الانسولين resistance اللي mainly نشوفها احنا بالtype 2 diabetic patients. It's different from sulfonylurea because metformin doesn't promote insulin secretion from the pancreas. ولهذا الهايبرانسولينيميا والhyperglycemia are less with metformin compared to the any of the sulfonylureas. Although the exact mechanism of action, أنا ذكرتها هاي before, the exact mechanism of action of metformin that have been used for many decades now to treat diabetes is not known. One of the main suggested mechanisms of action for the metformin هي reduction of hepatic glyconeogenesis. Metformin also showed to be slowing the intestinal absorption of glucose and promotes the peripheral glucose uptake and utilization, as we discussed. And more we see now that metformin is used for weight loss because it decreases the appetite in whether patients of diabetes or even normal people. According to the American Diabetes Association, metformin is the drug of choice to start with for patients with type 2 diabetes. ممكن نعطيه alone or in combination with other oral anti-diabetic drugs, or even along with insulin. الهايبوغلايسيميا احنا قلنا انه ما تصير من نعطي metformin alone. Our risk of hypoglycemia is less when metformin is given alone, but we may have cases of hypoglycemia when metformin is given in a combination with insulin or other insulin secretagogues مثل الsulfonylurea والglinides. لهذا maybe we need to adjust our dose of metformin. مثل ما قلت إنه الميتفورمين now is used for weight loss, is also used to improve insulin sensitivity in patients with polycystic ovary disease, because metformin lowers insulin resistance in these women. That will result in the ovulation and possibly pregnancy. أيضا عندنا مجموعة الثيازوليدين دايون أو جليتازونز اللي هي تشمل البايوجليتازون والريزوجليتازون. They are called insulin sensitizers. They don't induce insulin secretion, but they enhance insulin sensitivity in the whole body. This is through a mechanism that is that's involved the activation of PPAR gamma, which is a nuclear hormone receptor. By activating PPAR gamma, that will enhance the transcription of several insulin responsive genes that will result in the enhancement of insulin sensitivity in the adipose tissue and the liver and skeletal muscle. أيضا الجليتازونز ممكن ننطيها as a monotherapy, or we combined it with other glucose lowering agents or even with insulin. But if we consider combination therapy, we need to lower the dose of insulin if we add in the glitazones with it. طبعا الامريكان دايابيتس اسوسيشن recommends انه البايوجليتازونز او حتى الهوزجليتازونز they shouldn't be considered as a first line therapy to treat type 2 diabetes. They should be a second or even third line to treat type 2 diabetes. And the reason for that is because of the risk of cardiovascular disease that is associated with those. They don't need dose adjustment in case of renal failure or renal impairment, but there should be avoid in nursing mothers. مثل ما ذكرت إنه the main adverse effect of these candidates in this class هن myocardial infarction with death due to cardiovascular causes, especially with the rosiglitazones. لهذا حاليا the main use of rosiglitazones is limited to patients enrolled in special restricted access programs. احنا اللي نشوفه بالمستشفى وبالصيدليات انه استخدامه كلش قليل. الجليتازونز ايضا تستخدم to decrease peripheral insulin resistance او نشوفها بالبيشنتس اللي عندهم insulin resistance premenopausal women. نعطيهم جليتازونز على مود نقلل الانسولين ريزيستنس ونساعد بالحالات البوليسيستيك ovary syndrome على مود يصير ovulation and hopefully يصير pregnancy. أيضا another class which can be used for treating type 2 diabetes هي الglucosidase inhibitors وتشمل الأكاربوز والميجليتول. They inhibit the alpha-glucosidase enzyme in the intestinal brush border, and that will inhibit the breakdown of carbohydrates into glucose and other simple sugar. By doing so, they prevent the absorption of the carbohydrates. They don't induce insulin secretion or improve insulin sensitivity بالbody. لهذا risk of hypoglycemia is very minimal. However, when we add them to the insulin secretagogues or to the insulin as a combination therapy, the risk of hypoglycemia will develop. حاليا احنا نشوف انه بالكلينيك وبالصيدليات the use of these drugs is very minimal due to their adverse effect. أيضا من الكاتيجوريز المهمة هو الدايبيبتيديل بيبتايديز 4 inhibitors أو باختصار ال DPP4. وهذا الكلاس يشمل الألوغليبتين، ليناغليبتين، saxagliptin والسيتاغلiptin. They are all active DPP4 inhibitors and we mainly use them to treat type 2 diabetes. The mechanism of action of DPP4, they inhibit DPP4 that normally inactivate الانكريتين هرمونز. فمن احنا نثبط عمل DPP4 معناتها راح نشوف زيادة بالليفل اوف انكريتين هرمونز مثل GLP-1 اللي شرحنا عليه مسبقا. فهذا راح يؤدينا إلى prolonging the activity of incretin hormones. مثل ما حكينا إنه إحنا من incretin hormones will increase insulin release in response to the meal and reduce the inappropriate secretion of glucagon. طبعا بالtype 2 diabetes إحنا ممكن ننطيها alone, or we can combine it with sulfonylurea, with metformin, with glizone, or ممكن نعطيها ويا الانسولين. Unlike incretin mimetics, they don't cause satiety or fullness, or they don't reduce or increase the weight in the patient. الشغلة المهمة ويا ال DPP4 inhibitors هي إنه whether we give it before or after meal, the food doesn't interfere with the absorption of these drugs, and we can give them all ويا من يكون عندنا حالة diabetes with renal dysfunction without dose adjustment, except linagliptin that may need some dose adjustment. والجروب الأخير اللي عندنا هو الصوديوم جلوكوز cotransporter 2 inhibitors أو ال SGLT2 inhibitors. هذول يستخدمون لعلاج التايب 2 diabetes mainly. وعندنا 2 candidates بهذا الجروب هو الكلاجليفلوزين والداباجليفلوزين. مثل ما نعرف أنه الصوديوم جلوكوز cotransporter 2 هو responsible for the reabsorption of the majority of glucose in the tubular lumen of the kidney. لما ننطي هذه drugs will inhibit هذه channel. As a result, it will decrease the reabsorption of glucose into our body and will increase the urinary glucose excretion. Along with the glucose راح يطلع عندنا الصوديوم, وهذا راح will result in osmotic diuresis. بالنسبة للpharmacokinetics of these drugs, we normally give it once daily in the morning. بالنسبة للdapagliflozin, it doesn't really matter, we give it before or after a meal in the morning, before breakfast or after. بالنسبة للcanagliflozin نعطيها mainly before a meal. These drugs should be avoided لما يكون عندنا renal dysfunction for a very simple reason إنه إحنا main mechanism of action of these drugs is through the increase in the excretion of glucose and sodium. Due to the same fact, يكون عندنا adverse effects of these drugs هو بالفيميل يكون عندنا female genital mycotic infections such as vulvovaginal candidiasis, أو يكون عندنا urinary tract infection urinary frequency. لهنا نكون خلصنا part 2 of the drugs of diabetes. شكرا جزيلا. السلام عليكم ورحمة الله وبركاته.